Shiv. Thank you so much, everyone, for your time and for these 15 minutes for us to talk a little bit about our plans, about our history, and where we want to go. So I am a paid employee of Ono Pharmaceutical. I don't have any conflict of interest in the presentation that I'm about to give. I want to start here. There are two images that I can look forever. One sits in the basement of my home. It's a National Geographic view of the universe. And the other one is this. I can look at this for hours and we can talk and discuss about that offline. But if you look at, this is a composite picture of the night sky by NASA. And if you look at the map, it's just such rich history. You know, every dot in North America represents millions of people. The history that you can evoke by looking at Europe, the Trans-Siberian Railroad, the Indian plate hitting the Himalayas, and then Japan. I'll be in Japan next week, shining bright. And you go down, you see, you know, Borneo and Java, and then you see Australia and the great cities of the Gold Coast. And then you come to Africa, cradle of humanity, and you see the Nile shining brightly there up north, and then the great potential it holds. But my attention always goes to those two dots right here. I don't know if you can see those two dots right here, the Mascarene Islands in the Indian Ocean by Madagascar. One of the dots is Reunion Island on the left, and Mauritius is on the right. So we're going to be talking about Mauritius, about how this plan came about, and that's the place where I was born, and in a paradise island of 1.4 million people who came from all corners of the globe. Some came for adventure, others were tricked into coming to this people-less land where landless people came, and some were forced to it. But it's a middle-income country, as many of you know, and has a tremendous story about the incidence and prevalence of diabetes in that country. So I'm going to be focusing on that today. I have two cells for you today in the 15 minutes that you have. One is the emotional cell, and one is the intellectual cell. This is the slide for the emotional cell. Those are my parents that you see. And I can recall vividly the week before President Obama was elected in 2008, getting a call on a Saturday. That Saturday, that mom had passed away of a fatal ACS. She was a diabetic, and some say because he was heartbroken. My dad had. My mom was 59. My dad had a near-fatal thalamic hemorrhage, and that thalamic hemorrhage. Well, people said because he was heartbroken. I knew why it was, because he was an uncontrolled hypertensive. Looking at the MRI, just all whited out with white matter change. So all of that brought me to do what we are doing in the times on weekends, in the evenings, and the times we can, and that is to form this movement. This movement, I want to plug here. Over the last 15 years that we've been working on it, that has been tremendous help from so many members of the Harvard community. When I was choosing a place of training, many had told me, well, Shiv, you know, Boston is not the place for you. It's too rough, you're too soft. But you know, I've made my way. And yeah, I mean, you know, outside of Boston, there's a different view of Boston. Some of you might not realize it. But you know, when mom passed away, and I reached out to people, and they were very generous with the time in devising what has come to be the 520-35 movement. This is our mission statement. It's on the web. But at the core, we think that healthcare is an inalienable right and a collective responsibility. So that's the point where we start. And currently, we have over 500 volunteer adherents in 15 countries and territories. Mauritians, Friends of Mauritius. And we're dedicated to decreasing diabetes in Mauritius as a model for the world. But we have increased our scope to health for all, while focused centrally on decreasing diabetes. So what is the problem? Despite a lot of resources, and I understand I'm preaching to the choir here, but I'm recording this this meeting because I don't get time to talk, and so it'll go to a broader audience hopefully in time. Despite a lot of resources, healthcare in Mauritius and around the world is not meeting the needs of common citizens. The data are there, you all know it. 50% of the world does not have basic essential health services. 420 million people have diabetes but do not know it. 1 billion humans have uncontrolled hypertension. 100 million people around the world become destitute every year from healthcare costs. And to us, the start of the journey and my personal story and the story of everyone, every household in Mauritius, is that 40% of adults in Mauritius have diabetes or are pre-diabetic. And the rate of conversion of these pre-diabetics in 2 years is 100%. For those, so where do we begin? I have to say, you know, while in medical school at Vanderbilt and my training, preventive medicine and global health was as far away as you could get me interested beyond what we needed to do to pass USMLE for reasons that were whatever. But for someone who likes moving objects, Corrado Dascanio's dream was perhaps a place to start. So just to tell the story, Dascanio was a very well-known aeronautical engineer in Italy, and at the end of World War II, he didn't have much of a job. And Piaggio came to him and said, "Hey, make me something that will be cheap and many people can use." And so Dascanio drew a man sitting on a piece of paper, and then around it, he drew the Vespa, which the rest is history. If you love things that move, the Vespa is iconic. So what I want to direct here is that I didn't come to understanding or analyzing the problem with any bias. I just wanted to see what can we do to decrease this just unbelievable data and of 40% of people having diabetes and pre-diabetes, and there is no end in sight, despite amazing work that the government is doing and other stakeholders are doing. So we start with, and I'm putting this story in 15 minutes, but it's a 15-year journey. I'm just giving you the highlights, just where we ended in the insights that we have. So the core insight that is that may seem captain obvious, sort of an easy score on USMLE multiple choice, but consider that this insight has been around since the 1960s, that most healthcare needs are low to medium complexity and can be addressed in the primary care setting. And yet the healthcare systems around the world, for most part, do have obviously great investment in primary care, but the investment, if you look in dollars, is tilted towards high-end care and end-of-life care, especially in the OECD countries. The second insight is, you know, what I want to say is, how is 52035 unique in what I'm going to show you when compared to existing healthcare models? And in that, which is known, the natural order of things, but in practicality, to my view, has not happened. We see healthcare as a social institution. This term was generated in the 60s by White and colleagues, and were driven by, in thinking about how do we devise a system of healthcare within an existing ecosystem to be driven by inclusive capitalism and not that as monetized capitalist institution. These are tag terms, all of which we can discuss for a long time, but in the interest of time, I'll move on and can come back to these issues if we have time at the end. This is perhaps the philosophical place where I started. When I read the book by Just and Lasting Change by the Taylor family, it was an epiphany. And so they have proposed, as many of you know, the seed scale model, which is a highly effective social development theory. So what is it? And in summary, if you apply it to healthcare, healthcare is top down. So content experts like us go work with officials, the government, and other stakeholders, and we trust healthcare delivery to the community. While if you look through the lens of seed scale, and this is where we start with in devising the model that we have, that content experts, communities, and official work together. And this is just not a sort of just say so for a first paragraph of a grant, but really, how can we make sure that there is human reinforcement? How do we make sure that there is feedback, and how can we really make sure that the system is learning, continually learning in a learning healthcare system in medium to low resource setting? So that has been in the policy formulation, that has been our thought all along. And so this is the beating heart of the model. What we see as the community block that has 1,000 citizens locally, same cultural mix, and distributed in family units. And they will either select or elect a community health committee that will then interact with a community health officer. Now, this community health officer, this function currently doesn't exist, and we have been spending years in devising the curriculum for it. It is nothing is new under the sun, some would say, and this CHO, in the vision that we have, is a mixture of a community health worker, a nurse practitioner, and some elements of other types of healthcare workers in between the patient and the community and the physician. So a group of CHOs, community health officers, would be supervised by a community health doctor in our model. Next up is, let me go a little bit more about how we think we have built the community health officer in our vision of the 520-35 model. So we have clinical, under 3 pillars. We have clinical excellence, and community engagement, and research and training, which is learning health systems. These functions and these pillars of activity are not only for passing exams, but the community health officer will be rated performance based on these 3 pillars, as we can talk about it later. And so initially, as I said, we were thinking of conducting an impact assessment of this model in Mauritius, but a lot of conversation with a lot of people, really broaden the aperture with which we're looking to focusing on health for all, which can be achieved through this model, we think, while addressing the healthcare needs of Mauritius in diabetes and chronic non-communicable diseases. These are the goals of the impact assessment study that we are planning. And so this is the timeline and the ask. But let me go to the interesting part now, how we're going to, we're planning on setting up this, this study. So it is a cluster randomized clinical design where we will have each target community. So the target countries are going to be Mauritius, Waziristan, Pakistan currently, and Bihar, India currently. So within each country, we will have a cluster intervention arm where the community health officer will work. About 10,000 inhabitants subclustered in families. And then we also will have standard of care populations within that country to compare the impact of the model. So the impact of the model will be on clinical outcomes, but also on health economic outcomes. In part B of the study, part A would be study setup, part B would be a detailed healthcare survey within these communities. What are the morbidity and mortalities? And generating algorithms that can be easily low to medium complexity issues that can be taken care by the CHO. And then we are planning the intervention part of it over 24 months. And then within that part, we will start capacity building to maybe move to the control population and then on to insert. So every healthcare ecosystem is different. How it's going to work, this is part of the journey, and then impact assessment and report. I want to point out very quickly the 5 intervention modules that we have for the study plan. So obviously generating the clinical management algorithm that will be on a personal display assistant, a PDA, and then how that can be incorporated in the practice of the CHOs with supervision from the community health doctors, capacity building approaches. How do we use the energy that exists within communities to organize themselves around better health? I think community mental health is one of the big orphans in global health that now only amazing work by Patel and others and Dixon Chibanda in Zimbabwe are highlighting. So part of that CHO's work will be like a bench grandma in Zimbabwe, training lay people to do CPT and others. Next, of course, to be obvious, how do we use digital technology that is commensurate with the health ecosystem to leapfrog healthcare? And then importantly, in this top-down model, most healthcare is extractive. So the community doesn't get the benefit of the investment. It's always 90% of it is outside of the community. So we want to devise, the Pope has started this great organization of inclusive capitalism. You guys should look it up if you don't know. And so how do you invest in the community in healthcare? And I mean, if one of the projects may be a kitchen garden, rooftop kitchen garden, how can we have businesses that would set up rooftop garden in these communities that would then produce healthy vegetables that would then feed into that behavioral pattern of changing diet and behavior? So a lot to talk about that, but I wanted to highlight these 5 intervention modules. One of the exciting things that we're doing right now, we don't have much time, I see that, to go over it. We are planning a sub-study on the 520-35 diet. So this will be part of ICEHALL, but we are planning with Shilpa Vitaraju at the Harvard School of Public Health and Javid Zaki, who's the chair of computer science at Rensselaer, and Rajesh Jiwan, professor at University of Mauritius. We are going to be using artificial intelligence and machine learning to do the following. So basically go to these communities, these target communities, understand what are the food materials that are available in that community, what are the nutritional aspects of each of these food, and what are the recipes that the people use to cook daily food. And then using artificial intelligence as well as human alignment and reinforcement learning, how can artificial intelligence and machine learning, Javid and his team, design a diet that is closely related to the local recipes, but is more sort of transition towards the so-called Mediterranean diet. So that's the goal of it, and we are in early stages of planning. It's really exciting to be able to get the preliminary data for ICEHALL. And so in the last phase, I would say, what are the challenges that we are facing? The biggest challenge, I think, is the challenge of imagination, right? And all of us face that when we are proposing ideas. I've had people tell me over these years that the academic industrial complex is just too powerful to do something that is not part of the Politburo agenda. I had people tell me that people in Mauritius are way too stupid to be able to change this terrible diabetes situation. humbug I say to all of that. I think that because I have sat in meetings with young people crying to me, saying, we don't know what to do with this diabetes level. This is like a fire in our community. So there is interest in communities. It's just communicating in a proper manner and working with communities. So the second challenge that we have is the challenge of communication, of course, right? And the third challenge is challenge of politics. Look, I thought initially when I talked to everyone in Boston, this is probably the way that would work. I thought it would be one and done, and I'd go on to do other activities. But the politics and engaging with politicians, and if you start with the notion that all politicians are crooked, it's a no-go, right? There are a lot of politicians, whether in Mauritius or around the world, have good intentions. It's just getting to their imagination and communicating with them in ways that they understand has been a longer journey than I thought. Has been a great learning experience for all of us at the foundation. But I think the inspiration for us has always been that we are working on a reform movement as a long and difficult period of struggle during which you encounter the inertia and the opposition. But I think more than ever, after 15 years, we are closer to setting up ICEHALL, testing the impact, and we will see where things would go. So in terms of the journey onward, I'm after my visit to Osaka at Ono next week, I have the great pleasure of spending a week in Mauritius. We will have further stakeholder alignment towards preparation. We're working furiously on the ICEHALL paper, all volunteers, and building the protocol. We'll be gearing our Pakistan and India activities this summer, hopefully, and then, of course, looking perennially for funding. But what I wanted to show very quickly here is just to present what we are doing, and certainly ask for your help, input, and support in any way that you could. This is not what I do for a career, but we have been a sincere student of the area, and I think we have something that is of value. That's all I have. Thank you. I'll take any questions.